Type 3 receptor site. Obviously, this is an area we can place an implant, but we wouldn't attain the aesthetics demanded by the patient. We have to understand where the limitations are. The labial soft tissue in this case is deficient. The interproximal soft tissue, especially the lateral incisor, is also deficient by at least a couple of millimeters. So this is what we'd like to attain in the final case. And you see in the turquoise line, we'd like to rebuild the tissue in both of these areas. We'd also like to bring down the interdental tissue on the labial aspect of the central incisor. And if we basically mimic the contour and proportion of the left central incisor and make a mirror image, what we're really missing is this highlighted area here in terms of the soft tissue. And that's what we'd like to achieve in this case. So one of the first things we do is we do osseous and soft tissue augmentation utilizing soft tissue harvested from the tuberosity. I want to get tissue that will give me the density, fibrous density, to attain vertical augmentation. If you use connective tissue from the palate, invariably it has a lot of lipid content, and the fatty nature of that tissue. It's great for root coverage, but not as good for gaining vertical height in the ponic space. A little bit of bone grafting was performed in preparation for future implant placement. At approximately 3 months, once we gave them the tissue a chance to mature, we then reevaluate the aesthetic deficiencies. An implant was inserted into the grafted area, and this is something that I want to point out because it's pretty clear. What happens when you place your tissue is that the bone is still not there on the mesial aspect of the lateral. By the time we place our implant in our abutment, we're still missing the papilla because there was originally not enough bone to support it on the mesial aspect of the lateral incisor. So what we went ahead and did is we placed a temporary restoration on the implant in the right central incisor, and we initiated orthodontic extrusion to bring down the bone and soft tissue in the interdental area on the mesial of number 7. This is really simple tooth movement. I happen to think that this is something obviously that's near and dear to my heart as an orthodontist and periodontist, and my brother and I wrote the papers on this technique regarding implants back in 1993 and 1996. It's an underutilized technique that's very effective. What we do is we take the remaining attachment around the healthy natural tooth and utilizing slow tooth movement with light forces, less than 40 grams of force. Light wires are utilized. We use the implant as a primary anchor for the movement. We can slowly extrude this tooth over a period of half a millimeter of tooth movement a week. We can bring down the soft and hard tissues both on the labial aspect of the lateral incisor as well as interproximally. And if you take a look where we started, you can see the deficiency in the bone. And if you see as we erupted the lateral incisor, take a look at the angular crest that's been formed on that lateral incisor. That is the tissue that you're seeing being moved with the tooth. So as the tooth moves, the bone moves and the soft tissue comes down with that movement. So what we've basically done is taken this red line that you're seeing on the original view, and as we move the tooth orthodontically, is relocating that interproximal bone utilizing simple orthodontic tooth movement. This is not something you can do surgically. There's no bone graft that would have worked in this area for vertical augmentation around a tooth with a zero wall defect. So orthodontics in this case is not only practical, it's the only solution. So back in 1993, we termed the term that orthodontic extrusion allows for implant site development through the enhancement of both the bone and the soft tissue, and we've been using it ever since. So we've taken a patient such as this one using a combination on a class 3 defect, using a combination of bone and soft tissue grafting, and then being able to enhance the results of the surgical components of the procedure with orthodontic extrusion. Now we have a solid implant in the area of the right central incisor. We've rebuilt the site from type 3 to type 1, but we have a challenge now. And the challenge in this case is, what do we do with the lateral incisor? It's a short root, it is mobile, and it cannot retain an individual crown. It's not suitable abutment for a single crown. So the question remains what to do in this situation with the lateral incisor. We've been able to bring down the soft tissue on the labial aspect. We've erupted the lateral incisor and brought down the interproximal soft tissue. We've also been able to reestablish the contour of the papilla at the midline. So the type 3 has been reconstructed into a type 1 site. We've also gained the harmony of the interdental soft tissue heights and the labial soft tissue margins utilizing a combination of surgery and orthodontics. But now that we've attained this, the question again remains what to do with the lateral incisor. Should we take out the lateral incisor and place another implant? Well, the problem with placing an additional implant in this situation is with two adjacent implants, we always know that we have a problem of being able to segregate these implants by at least 3 millimeters. And even if we segregate the two implants by 3 millimeters, we will lose the effectiveness of the support for this papilla. It'll go from 4.5 millimeters to 3 millimeters. So placing two implants from an aesthetic standpoint would cause resorption of the bone in between the implants, and we will end up with a minimum of 1.5 millimeters of soft tissue loss interdentally in an area that is of vital importance to the final aesthetics. So this is a very tough question probably for most of you in the audience, and I would love to see some of you maybe continue. I see a lot of questions coming in right now. If you can text them and we will go over them as part of the final case. It will be very, very, I think, interesting for many of you. A lot of different options today. We have smaller diameter implants that we can use to segregate the implants from one another. But invariably, even if we do, we're always going to be challenged with the interdental tissue. The labial tissue is okay, but the interdental tissue is always going to be a challenge. So two implants, very, very challenging. You may lose some of the effect that you had from orthodontic extrusion. You may lose some of the papilla height. The next question is, can you splint the implant to the natural tooth and maintain that lateral incisor? There's a big controversy on that as well. Many people say that if you attach a tooth to an implant, the implant is basically cantilevering the effect of the forces to that lateral incisor anyway, and over time the atrophy of the periodontal ligament on the lateral incisor may cause intrusion of that tooth. Another option is to extract the lateral incisor, remove it, do a socket preservation procedure, as you've seen many times, Kobe Landsberg and many others talking about socket sealing, and then use a cantilever pontic of the lateral incisor. What we've been doing over the last several years, and since the topic of this course today was new tools and technologies, and we talked about some of these today, utilizing CBCT and all this other technologies and alloderm and bioactive modifiers, is that we utilize a root submergence technique. And what basically we do is we take a tooth like this, and rather than just simply extract it and having to augment it with a socket seal procedure, is we cut the root that's in the bone down to the crest of the bone, and we cover over the top of it with a soft tissue graft. Why would we do that? It's been used in dentistry since the 60s under dentures, root submergence. We recently published an article, there's many articles on this technique, because what it does is it preserves the attachment of the periodontal ligament to the bone, and therefore we don't lose the crestal bone when you maintain the root. If you extract the tooth, and we know from Ron Nevin's work, and many, many others, is that there is, even with the grafting of these sockets, up to 20% of the labial bone at the crest can be lost. Jan Lindy says at least 1 millimeter, and he coined that area, or termed it, the bundle bone. I happen to be in agreement. So I don't want to lose the volume of the ridge on the labial. I don't want to lose that attachment, and I certainly don't want to lose the height of the interdental papilla. And if you take a look at what we did here, a single implant restoration with a cantilevered pontic over a submerged root tip. If you take a look at some of the measurements from the literature, and over the last decade there's been many of them, we've tried to come up with some of those numbers with work done by our own group as well as Dr. Tarnow and his group in New York. And when we have an implant next to a pontic, we can be as much as 5.5 millimeters away from the bone to the future contact point. Two implants next to one another, it can be as much as 3.5, really it's 3.4, and an implant next to a natural tooth, 4.5. Let's take a look at the final case before we break for question and answer. A patient that is in dire need of tooth replacement with implants. We retained a few of these hopeless teeth just to retain a prosthesis during the grafting and implant stage of treatment. Here's the temporization in place, and what we're seeing is, unfortunately, a very, very large defect, a class 3 defect, on the maxillary right segment in the area of the central, lateral, and canine. And if you take a look at the left side where he retains some questionable or guarded teeth with remaining decay, you can see that the soft tissue and bone on the right side has been compromised both horizontally and vertically. What we attempted to do in this case to attain the aesthetics needed is to utilize a combination of implant placement and allograft block to support the contour of a pontic in the area of the lateral incisor. So what we're seeing here is implants placed into a previously grafted area and then an allograft block. This is a J block from Zimmer, Tutagen. This is irradiated bone utilizing the Tutagen concept, and this irradiated allograft block is then carved, and we utilize a stereolithographic model to shape the bone on a sterilized stereolithographic model. And as you can see here, the attempt is to support the soft tissue both horizontally and vertically. Whenever using this bone, it is very important that it is stabilized, that there's absolutely no micromovement. I always infuse this material and soak it in a bioactive modifier. My preference is autologous plasma-rich growth factor, PRGF. I know today a lot of people are now using PRF, Shukrin's concept, but some type of bioactive modifier. And it is vitally important that we maintain tension-free closure over that block graft. And you can see on the right screen, after suturing with the Gore-Tex sutures, we vertically extended the flap, coronally positioned it over the implants and the healing abutments, as well as the J-block material. And what you're seeing on the screen on your right is several months later. You want to leave this bone in the mouth for at least 8 months. If you're going to think about placing implants, at least 8 months before you go back in and place implants into this bone. And if you take a look at these x-rays that were taken, this is approximately 8 months, you'll notice the implants have been restored. These are ankylosing implants with platform switch concepts, again with balance abutments in the anterior region. And then in the area of the J-block, you can see the screw that's retaining the J-block, and that shape that is going to support the labial and interproximal tissue in the ponic site has been retained. Let's take a look at where we started with a severe class 3 defect, reconstructed now with a combination of bone from a J-block and implant placement. This is where we started, and that same line now with the implants in place. You can see the canine, the central incisor, and the soft tissue of the pontic site being supported by an allograft J-block material. We're very excited. We've done several of these cases over the last few years. We're probably going to be publishing on this concept in the next year or two, so please keep an eye out for the publication. It's worked well in the anterior maxilla. I've not been a big fan of its utilization in the mandible for a variety of reasons. But in the maxilla, this piece of bone for the support of a ponic has worked quite well. The final restoration, again, the concept of cone beam technology, being able to plan these cases from the outset and then being able to secure the appropriate placement of our implants. And you can see here a number of these implants being inserted, a retained block graft for the ponic site on the right side. And again, when we're able to place our implants and being able to now see them post-operatively and evaluating these concepts on CT, by post-op CTs, we're able to actually see in this patient that we've been able to maintain the facial bone as well as the lingual bone around these implants, and we start to evaluate how high up on these platform switch abutments are we able to maintain the crestal bone. A 1-year post-op, and again, taking a look at this, you can see we have the bone, continuing to preserve the interproximal soft tissue and the labial in the area of the ponic. Zirconium abutments were utilized. This is the day of insertion on the left screen, 1-year x-ray on the middle screen, and then a 1-year post-op of the ceramic restoration on the right screen. And what you're seeing is an implant in the canine, a pontic supported by the allograft J-block, and then an implant in the area of the right central incisor. I'd like to thank you all for participating in this webinar, the first webinar of many for Dental XP. I hope that it has given you some ideas of how we utilize some of the new materials, where we use them and how we use them. And I hope it'll pique your interest to come back and join us. What I'd like to do is take some of the questions that have been posted during this webinar session and to answer them. And I think that that would be something that would probably be something that many of you may want to listen to. So some of the questions have been asked from Bern, Switzerland. Do you prep the abutments prior to surgery, and how do you calculate how much needs to be reduced? The answer to that question for us is that we prefer that we use pre-contoured abutments. We really don't like to prepare the abutments in the mouth at all. So there's many systems today that offer us the utilization of pre-contoured abutments or aesthetic abutments, and we prefer that we minimize the amount of preparation that's needed. If preparation is needed, what we would prefer to do is do something that we do in the lab, where we do a reduction coping, that the lab tells us how much needs to be reduced, and we place the coping over the abutment and then prepare it out of the mouth on a model before we insert it. One of the questions as well from France is, according to Tarnow, it is not necessary to graft the gap between the implant and the immediately placed implant and the socket walls. I have heard that lecture as well. I'm obviously very fond of Dr. Tarnow and have had the pleasure of lecturing with him and publishing with him. And I can tell you that I believe he's entirely correct, that you can just allow a blood clot to form in that gap between the implant and socket wall, and you will get osseointegration. The problem that I see in clinical practice is that you get shrinkage of the ridge, and that although you get osseointegration, you may lose some of the soft tissue and the aesthetics that is needed. So therefore, I prefer to graft that gap, not for osseointegration, but to actually maintain and preserve the width and contour of the ridge. I'll take another question. Is it possible to use a CIRAC for a temporary restoration? This is from Italy. Yes, as a matter of fact, CIRAC and CAD/CAM technology is something we've been working on, and it absolutely can be utilized. You can pre-scan these abutments with a CIRAC machine. You can then store it in its database and then scan it in the mouth once the abutment is inserted, and have a CIRAC fabricated as a temporary or even a final restoration. So absolutely it can be done with any system. Pre-scanning of the abutments, storing it on the computer. We've been doing that, and we've been very happy with some of the early cases that we've been doing. One of the questions is, would you ever consider extraction and doing an ovate ponic? Of course, I think we consider that treatment all the time, and this question is from London. But the only issues with that is that you really have to decide whether or not the root that's being extracted can be maintained and submerged. We've been submerging even vital roots to maintain the attachment, because the best ponic for us that we've seen around our implants is when we have a pontic space, an ovate ponic over a submerged root tip. We've had so many questions. I was just so very happy at the response tonight. We've had over 200 people. We've cut it down to 200 that we've allowed for this session tonight. Dental XP is a fast-growing dental community. I'm just amazed by the responses, so many questions. Another question, this one is from Russia. Do you think that mesializing the canine and transforming it into a lateral incisor would have been another option in the case where we had a lateral central restoration. And I think that there's no doubt that moving a canine into a lateral position would have been better from an aesthetic standpoint for the implant, being able to have just one implant rather than two. The problem with mesializing a canine into the lateral position is from a functional occlusal standpoint. You're now moving a very large canine into the lateral position, which is harder to handle aesthetically in terms of managing it from a restorative standpoint. And also now you don't have a canine in its proper position for canine guidance. There is another question. Using the same concept, ortho-extrusion, is bracketing 3 teeth enough? The case that you saw that I used orthodontic extrusion, and by the way, for any of you that are interested, I do a 2-day hands-on course on orthodontic tooth movement, and where the second day is hands-on, where we talk about the simple adjunctive tooth movement for the non-orthodontist. If anybody's interested, they can go to Dental XP and take a look at when dates that course will be offered. As far as the 3 teeth are concerned, if an implant is one of the anchors for the tooth movement, then I think that 3 teeth are enough, because the implant is a suitable anchor for the tooth movement, especially extrusion. But if you're going to be utilizing natural teeth, then I believe that you should bracket at least 2 teeth on either side of the tooth that you're moving for optimal or at least suitable anchorage for tooth movement. One of the questions was, what from Canada, what temporary restorations were used during treatment? You have a couple of options for a removable prosthesis. I like to utilize an Essex retainer from Raintree, which is now owned by Dentsply. I like to use 035 material. This is a vacuform matrix with denture teeth. And for a fixed temporary restoration, you really have an option. We use acrylic restorations as well as composite temporary restorations. It really depends on your comfort level. I had again very nice comments from all over the world: Spain, Portugal, and many students from around the world. So I think for any first-time subscribers to Dental XP, I believe that if you would like to join this evening, a few of you are students that have asked for a premium discount to join the site. We'd love to have you. I'm looking forward to continuing to do these webinars and to continue to be involved with the scientific committee to bring other experts over the next few months. We may have people like Ziv Mazor and Mike Picos who may be also giving these webinars as part of Dental XP's premium accounts. Premium discount code for this evening, if you place it in, it'll be good till the end of the week, is XP23. That's XP23 for those students out there that ask for a discount for a premium membership. I hope you join. One of the questions as well from Colombia, South America: if the defect is type 3 and an implant is placed in the area, how would you preserve the bone that's been grafted? I think it's a very, very good question. I think that there's a problem with being able to predict how much of that bone is not going to resorb. And what I've been doing is when I place my implants, I use additional bone grafting. And what I would use in those cases is a product that has a low turnover. A low turnover product would be a xenograft product. And as I said before, in Europe I've used Latic. You can certainly utilize BioOS. You can use PepGen. Anything that would allow you a low turnover product to preserve the bone that you grafted into those type 3 defects would be rather ideal. So I think from that standpoint, I would these days graft additionally. Even if you have the bone, I mean, you have the bone, you place your implant and it's not peeking through, I think it really is a very good idea to do additional grafting with a low turnover product the day of placement into your graft. Let's see, I think that one of the questions, do you manage the soft tissues with provisional crowns prior to permanent? This will be the last question of the evening. Do you manage the soft tissues with with provisional crowns prior to the permanent crowns being fabricated? And the answer to that is maybe not in the unesthetic areas of the mouth, maybe not in the posterior regions, but in an aesthetically demanding area. We always temporize first, and we want the ideal temporary to be in place for at least 3 months. The literature shows that 95% of the remodeling of the soft tissue occurs in the first 12 weeks, and at 12 weeks or after is an ideal time to take your final soft tissue mold and impression, and then take that to the lab for final restoration. I'd like to thank the worldwide Dental XP community for joining me this evening and in our inaugural webinar. We're looking forward to more. We've had a great response. Please tell your friends, come to the blog, join us. We really are looking forward to, we now have over 24,000 members in over 180 different countries around the world. I'd like to thank all of you who have made this site so popular, and I look forward to seeing you again here at Dental XP. Thank you very much, and good evening.